Afternoon. Just letting a couple more people shuffle in to our very exciting distinguished speaker series talk that we have today. Okay, looks like we're asymptoting on attendees. So let me welcome each of you to the Institute for Addiction Science Distinguished Speaker Series. We're really glad that you're here. Just a little bit about our institute. We are a multidisciplinary group at the University of Southern California, and we take an all hands on deck approach to fighting the addiction crisis. And part of that includes having really smart and accomplished and experienced people come talk to us and talk to the community about how to really make change. And so we're really excited about Miss LaBelle, who will be speaking today, and really excited to have Dr. Ricky Blumenthal, who will be the moderator. And so before I turn it over to Ricky, I just want to thank you for attending, folks. Thank our sponsors, which include the Provost's Office at the University of Southern California, the Dwork Peck School of Social Work at USC, the School of Pharmacy, the Keck School of Medicine, the Cancer Center, and the Department of Population and Public Health Sciences. So with that, I'll turn it over to Ricky. Thanks.
Thank you, Adam. And I'll introduce the speaker, and then there are two ways for you to ask questions. You can put them into the chat, or there's a Q&A button that you can put in. And then at the end of Ms. LaBelle's remarks, we'll open it up and go through the questions that are put into the chat. Regina LaBelle is a distinguished scholar and director of the Addiction and Public Policy Initiative at the O'Neill Institute at the George Washington University Law Center. She works at the intersection of law and policy, and her work is focused on identifying policies to reduce overdoses and using the law to promote access to quality addiction treatment, harm reduction, and recovery support services. She also directs and is an adjunct professor in the Masters of Science in Addiction Policy and Practice program at Georgetown University's Graduate School of Arts and Sciences. She brings decades of public service to her work at Georgetown University. Most recently, LaBelle was appointee in the Biden-Harris administration and served as the acting director of the Office of National Drug Policy Control. National Drug Control Policy, sorry, I knew I said that wrong, in the Executive Office of the President. And there she oversaw Biden-Harris administration's drug policy priorities, including the focus on harm reduction services. Prior to her federal government work, she was the legal counsel to the Seattle Mayor, Greg Nichols. And she was in that role for 8 years, sorry. And from 1998 to 2005, LaBelle was an adjunct professor of policy and ethics at the Seattle University Institute for Policy Studies. She received her JD from George Washington University Law Center and a BA from Boston College. And welcome, Ms. LaBelle. Looking forward to learning from you today.
Thank you so much, Ricky. And thanks so much for having me today. I'm going to get my slides set up and share my screen. Hold on for just a second. Okay. So what I want to talk about today is, as Dr. Blumenthal said, I've had extensive experience both at the federal and the local level, and I want to talk about translating science, research, and evidence to policy, and how sometimes that works and sometimes it doesn't. So let me go to, as Dr. Blumenthal said, I head up this Addiction and Public Policy Initiative at the Law Center, and I also head up this is a new Master of Science in Addiction Policy and Practice in the Graduate School at Georgetown University. And the purpose of this program, it's a one-year program, the purpose of it is to build out a addiction policy workforce to go and put into practice a lot of the great science that you all do here. So what I want to talk about today is policies that, our goal in the Biden administration and the Obama administration and the Office of National Drug Control Policy was to pursue addiction policies that were rooted in science and evidence. And how does that work or not work? And I'm going to talk about where we are, how we got here, and where we should go in the future on addiction policy issues. So how did we get here? First of all, I know you know this data very well, but I think it's really important that we start out by talking about the 100,000 overdose deaths that we've experienced in this country. And this is from October 2020 to October 2021. And the change there's only a few states that have seen a decrease in overdose deaths in that same time period. But nationally, it's been about a 16% increase in that 1 year. And drug overdose deaths are having a disproportionate impact on certain communities. We've seen increases in Black communities, in American Indian and Native American populations, Native Alaskans nationwide. And this is a trajectory that is occurring over time in our country that has really changed from the time when I first started working on issues relating to overdoses. We're seeing it impact a larger demographic group in the country. So what I want to talk about is that's really if we were to develop a system that was intended, an addiction policy, if we were to create addiction policies with that were intended to create bad outcomes, that's kind of what we've done. And how did we get here? I'm not going to start from the beginning of our policies and how they were all created, but I do want to start with 1989. This is a quote from a Washington Post editorial. Now, Bill Bennett was the first drug czar. He was appointed by the first Bush administration. And as you can see, this is directly from the Washington Post editorial, that his principle in writing the National Drug Control Strategy, which is the executive branch of the United States government, it's the policy priorities and strategy that is intended to guide all drug policy in the country. And as it says, he wanted states to put in laws in place. He wanted the federal government to put laws in place that would not allow anyone to get off on a drug possession charge. That's what he says specifically. Have the states revoke driver's licenses of users. Make federal aid to colleges dependent on more serious anti-drug programs. And pour much more money into law enforcement at every level. And double the capacity of the federal prison system. And the Washington Post endorsed that plan at the time, saying, well, it's going to cost money, but it's worth it. And that's exactly what happened. So if you look at this next chart, you can see the trends in US corrections beginning at about this time. They're not all drug convictions, obviously, but the drug convictions certainly spurred this large increase in in incarceration rates at both the state and the federal level. What else happened? The other piece of this was the crack cocaine sentencing disparity that was set up. And in the Anti-Drug Abuse Act of 1986, it mandated that the 5-year minimum sentence for a possession of 5 grams of crack was the same as 500 grams of powder cocaine. So you can look at the measurements here. That was put into place, and that helped spur our increase in sentences around the country. And then collateral consequences. Collateral consequences obviously are consequences that stay with an individual past, and these are for nonviolent drug convictions. So collateral consequences that stay with the individual past their incarceration. They go they can include certain state licensure. They could, at the time, include access to educational grants or loans that are guaranteed by the federal government. So they include a plethora of items. And that, again, that was all spurred as part of this effort to really crack down, not just on drug trafficking, but drug use as well. We're talking about science and evidence. That's what many of you do. And what we do know is that more imprisonment, the research has shown more imprisonment doesn't reduce state drug problems, as it states here in this Pew Research report. And in fact, what this report found was that the individuals who were mostly incarcerated were lower level in the drug trafficking networks. They were lower level individuals. So basically they were just replaced. They may have been incarcerated, but they were just replaced by other people. And so it had no effect. Now, I apologize because I know this sounds self-serving because I served in the Obama administration for 8 years, but I do think it's worth saying, talking about some of the ways in which we sought to change this, to shift this. Now, some of it certainly was rhetorical, and this article points that out. I worked for Michael Botticelli. He was the first person to be the head of the Office of National Drug Control Policy, to be in recovery. He was also the first individual in that role who came from a healthcare perspective, a public health perspective. But the most important piece that happened during the Obama administration was the passage of the Affordable Care Act. And I want to point that out, especially today. It was 12 years ago today that that law passed. And so what that Affordable Care Act did were two things. One is it expanded access to treatment. It expanded access to healthcare for individuals. But at the same time, it also ensured that that substance use treatment, mental health conditions would be part of the care that is allowed and provided under the Affordable Care Act. The other piece that happened that was important at this time was Medicaid expansion. And that is not in every state across the country, but Medicaid expansion allowed individuals who would not otherwise be eligible for Medicaid to be covered to receive care under Medicaid. Now we have a much further way to go in terms of making sure that that promise is kept and that individuals who receive care under the Affordable Care Act or care under Medicaid, that they actually get treatment. That still is not the case. We only have 13% of people in this country in need of treatment who receive it. But the Affordable Care Act at started that effort. The other piece that's important was the passage of the Mental Health Parity Act, which requires insurers to provide coverage for mental health and substance use treatment at the same level as they do for other conditions. Again, there's a lot further that we need to go in terms of enforcement of the Parity Act, but that's another piece that was passed in the past 10 years. So I want to talk again, I'm talking about the policy process. How is the policy process made? How are these policies made? How are they determined? So in 2020, the Biden administration, or not the administration at the time, the Biden-Harris campaign set up agency review teams. And this was prior to the election. So I served on the agency review team. And what we did was, at the time, we met with hundreds of individuals from across the spectrum of perspectives on the Office of National Drug Control Policy, but also on addiction issues, on treatment issues, prevention, recovery, harm reduction. We met with a number of individuals. We asked them all the same question. What's the low-hanging fruit? We have two goals here. One is to build out the type of addiction system that this country needs that is evidence-based. And what can we do in the short term to reduce overdose deaths? Because at the time we knew we were going to reach that 100,000 threshold. And while 70,000, 80,000, 90,000 is too much, 100,000 is a record number of overdose deaths. And we knew we had to act fast. So we asked about the low-hanging fruit. And I put this in here because I'll tell you, as the process was going on, I had to keep saying, are we not defining low-hanging fruit correctly? Because to us, low-hanging fruit was something that was obvious or easy, that could be done, that can have the biggest effect. But I think some folks identified low-hanging fruit as obvious, just obvious, not necessarily something that's easy, but something that you should do this, regardless of how hard it is to get done. And in today's political environment, it's very hard to get even the most basic things done. So this is what identified as a low-hanging fruit, and these are important items. Easing barriers to methadone access. Eliminating possession charges for drug use alone. Stopping laws, and much of this is state laws, but stopping laws that penalize parents for drug use alone. That includes removing children. Access to medications for opioid use disorder during incarceration. Supporting syringe services programs. There's still states in this country that don't allow them. Scaling up harm reduction, even articulating the term harm reduction. Removing the X waiver for buprenorphine and eliminating what I talked about before, that crack cocaine sentencing disparity. It went from 100 to 1 to 18 to 1, but still it's 18 to 1, and there's no scientific basis for that. So when we talk about what's obvious or easy, right? None of this is really obvious. I mean, all of it is obvious, but none of it is very easy to get done. So in the first couple of months of the administration, we were required to issue a set of drug policy priorities. And these drug policy priorities had to guide our work. The Office of National Drug Control Policy is in the Executive Office of the President. What the agency does, it has less than 100 people. And what it does is it guides in developing the strategy, and these policy priorities guides the work of other agencies through budget authority, but also by kind of coordinating and bringing the interagency together to identify what the priorities are. So when we were looking at these issues, we wanted to figure out what, obviously what was going to make the biggest difference. And we really had to look at two things. Number one, can we do this through executive action? And executive action is something the president can do. The president has authority to do based on, it could be a policy, it could be a regulation that the executive can change. Or secondly, is it a legislative action? Now, legislative action is obviously a little more difficult, even though Congress is, the Democrats have the House and a simple majority in the Senate. It has to be bipartisan if you're going to get it done. And also, most importantly, you have to have, from the executive branch's perspective, you have to have an agency consensus. So an example of that is the X waiver. You need the consensus of every agency that has equities in that. And HHS has equities in that, as does DOJ and DEA. So what we did was we identified our policy priorities. We issued these in April. And they were general and broad, but we had identified action steps under each one of these items. The first is expanding access to evidence-based treatment, advancing racial equity in the approach to drug policy, enhancing evidence-based harm reduction efforts. And I want to pause there for a moment, because while it may not seem significant to people who work on this issue every day from a science perspective, this was the first time that the Office of National Drug Control Policy articulated the term and included harm reduction in a document of this type. Supporting evidence-based prevention efforts, reducing the supply of illicit substances, And then recovery-ready workplaces, and expanding access to recovery support services. So all of that was in the policy priorities. And, so when you come into an agency, when you come in to a new administration, the reason why those agency review teams were so important, the reason why that transition time is so important, is because you want to get moving fast. You want to make sure that what you have to get done, you act on early in the administration. So we did a couple things early on. In April, we released the policy priorities, but we also at the time released practice guidelines. And the practice guidelines removed barriers for prescribing buprenorphine to 30 or fewer patients. And the intent of this is to make it easier for prescribers who are prescribing to a limited number of individuals with opioid use disorder to allow them to prescribe buprenorphine to treat them with evidence-based care. And this had been done in January in the Trump administration, but it was when we came in, there was a feeling that it wasn't done correctly. So it was revised and we reissued that in April. And that was through a practice guideline. So it was an executive action that could be taken. It is impossible for the executive branch to act unilaterally to get rid of the X waiver entirely, but this is something that could be done. In May, we removed a federal restriction on purchasing fentanyl test strips. So the last administration had issued a blog post opposing fentanyl test strips. And so it was perceived that that prohibited federal funds from being used to pay for fentanyl test strips. So we issued this again, that was something, all we needed to do was remove the blog post. And then we issued we sent information out to states, we've sent information out to grantees that you can now use federal funds for fentanyl test strips. However, the fact remains that many states still consider fentanyl test strips to be drug paraphernalia. So states are looking at how they can change their laws now to allow this. Sorry, I need to go to my next slide. In June, the administration issued a long delayed rule allowing for mobile methadone units to provide methadone to individuals in rural areas or in corrections. This had been, a moratorium was in place since 2007 that did not allow for any new methadone vans to be approved. So it went through the rulemaking process for 10 years. So in June, the rule was finally released. It is out, and the intent is to allow more flexibility for methadone bans. We also, in that first year, extended the public health emergency so that telehealth and take-home methadone regulations that were revised during COVID to allow for more take-home methadone, for example, were extended. And then we did two other things that I want to mention here. We worked with the National Academy of Medicine to set up a workshop to identify how to modernize the nation's regulations on methadone. And then there was a $30 million grant specifically for harm reduction that was issued under the American Rescue Plan that went out for proposals through the Substance Abuse and Mental Health Services Administration last year. There's a couple other things that are important that have been undertaken that I do want to mention also. Litigation was brought against the Pennsylvania court system just in the last couple of months regarding the denial in many cases of allowing for people who are in the court system to continue using medications, methadone or buprenorphine in the court system. And then last but not least, New York State opened its overdose prevention site. All of this happened last year. So the president's budget went to the Hill and it called for increased funding. And it also, importantly, called for a 10% set aside in the largest grant program that comes out of the Substance Abuse and Mental Health Services Administration, a 10% set aside in the block grant for recovery support services. That went to the Hill, and unfortunately, much of what the president had included in the fiscal year 22 budget was not passed when Congress finalized the budget in the last month. The other important piece of that we were hoping to get passed in the budget was lifting the restriction on using federal funds for syringes. At the last minute, that was put back into the appropriations bill. So still the federal funds cannot be spent to purchase syringes. And that was for the fiscal year 22 budget. So I want to talk about now what's left. I mean, there's obviously a lot left to do, a lot more that we have to do. And one of the issues that I testified before the Senate on in last year was finally eliminating this crack cocaine disparity. And I want to say, when we talk about bipartisan issues, this one is bipartisan. However, it still hasn't gotten passed in the Senate. So science and evidence, there's no scientific basis for the sentencing disparity, but it remains 18-1. And it has passed the House, but it has not yet passed the Senate, even though when I testified, I did so with Arkansas Governor Asa Hutchinson, not a very liberal governor. But on this issue, he feels very strongly, and actually he's felt very strongly about this issue for decades. But it's still not gotten the support that it needs on a bipartisan basis to get through. So what are the other pieces that need to be done in the coming months, years before the administration's over, and even beyond that? I mean, many of these issues extend beyond administrations. So first, we have to integrate addiction treatment, prevention, and recovery into mainstream healthcare. We know that this will allow more people to have access to quality care and early interventions. The flexibility for telehealth and take-home methadone. Now, this passed in, or the executive did this in the Trump administration right after COVID started. The intent of the flexibility was to ensure continued treatment at a time when social distancing became necessary. And the flexibility appears to have had positive results. There's some research ongoing, but a couple of things that are worth highlighting. First, a survey from North Carolina found there was very little diversion of take-home methadone. And other reports found that people were retained in treatment longer because of these additional flexibilities. There's also some surveys of people who are receiving methadone. And one of the quotes I thought was very compelling. This individual said, "It made me feel more like a normal part of society to be able to have my take-home methadone." And it allowed people to retain longer in treatment. Now, some states are already backing away from these telehealth flexibilities, and certainly Medicaid reimbursement issues remain, even if the flexibilities are extended past the COVID public health emergency. Another piece that's important that remains to be done is syringe services programs. They serve a population, as you know, that are great risk for overdose and bloodborne disease, such as Hep C and HIV. And they require ongoing funding and the support of states and local communities. Workers at syringe services programs, we know, engage people who use drugs, provide them with testing, referral to treatment, and other services that reduce their risk for overdose and bloodborne disease. And very importantly, the services are provided without stigma. Now, the science all shows this, right? They save taxpayers money. The Indiana State Department of Health credited syringe services programs, saving taxpayers an estimated $120 million by reducing bloodborne diseases that are associated with injection drug use. And in another area that we know there is research to back this up that needs additional work at all levels of government is improving access to treatment for people who are incarcerated. To move away from incarceration, and also we know that we have to move away from incarceration for people for non-violent drug crimes, for people for possession solely. But one of the groups that's most at risk for overdose are people reentering society after jail and prison. The reentry population is up to 40 times more likely to die of an opioid overdose within a year of release from incarceration than the general American public. And of course, it's mainly due to diminished opioid tolerance while they're incarcerated. Now, some states we know are providing evidence-based treatment for incarcerated people, but this is still much more the exception than the rule. And the evidence shows that providing medication for opioid use disorder to incarcerated populations reduces overdoses, and people treated with medications for opioid use disorder while incarcerated are 75% less likely to die of any cause and 85% less likely to die from overdose after release from a jail or prison. And there's new research released from NIDA that says they're less likely to recidivate. There's also an area that we did start working on was paying attention to the connection between adverse childhood experiences and early substance use that may lead to later substance use disorder. There was a proposal in Congress last year that you probably heard about to extend the child tax credit. The child tax credit, we know, lifted millions of children out of poverty. And it reduced those conditions that can lead to later substance use disorder or risky substance use at a young age. But Congress failed to extend this child tax credit, again, despite the evidence and the science showing that it lifted children out of poverty. And the last thing I want to talk about is just the role that we all have to play in reducing stigma. And there is lots of research that's been done on this about the role that stigma plays in limiting access to care for individuals with substance use disorder, but also the role that stigma plays in getting people who are drug users the health care or the services that they may need. So we have to humanize people with substance use disorder to get them the help they need rather than demonizing and punishing them. And this means reaching out to people who may be experiencing addiction in their own families and not shaming them. But it also means that medical providers have to recognize the role that they play in screening and treating people with substance use disorder. Now, one way this is manifested is pharmacies that fail to stock medications such as buprenorphine to treat opioid use disorder, or failing to carry naloxone, which is, we all know, the medication that reverses an overdose. For example, one study of pharmacies in areas with high rates of overdose found that 1 in 5 pharmacies surveyed would not fill buprenorphine prescriptions. There are a number of reasons for this, including concern about government oversight, but when 100,000 people are dying of a drug overdose annually, we are in the middle of a national emergency, and that means we have to change course and take the steps to increase access to these life-saving medications. So everything that I've talked about, from integrating addiction treatment into primary care to expanding syringe services programs and providing treatment to people with opioid use disorder while they're incarcerated and moving people away from incarceration. These are actions that all have to be taken to bring down overdose deaths and reduce addiction in this country. Now, I want to close finally by just mentioning in memory, because I know that all of you probably hear this, and I'm just going to say in the last 4 days, I have had close family members tell me about people that they know in their community who have lost loved ones to overdose. And I think it's really important. This is from Overdose Awareness Day, which is held in August, but really every day has to be a memory in memory of these people whose lives we've lost, because we've lost over 500,000 individuals to overdose now, not to mention the people that are left behind and the communities where that feel this loss and their loss. So thank you very much for your time. And this is my contact information. Ricky, I'm happy to answer any questions that folks may have.
Well, let me first thank you for your wonderful remarks. I'm kind of sitting here a bit shell-shocked, thinking about the fact that the former head of the Office on Drug Control Policy, so clearly lay out the case for a new approach that would preserve life and improve well-being among people who use drugs. So thank you very much for your thoughtful remarks. So if you have questions, please enter them either into the chat or the Q&A. Unfortunately, we don't have the capacity to allow you to ask your questions directly, so I'll just be reading them off. So the first question is from Christopher Sharp. When the term evidence-based is a key aspect of policy priorities, how does this impact the priority to advance racial equity?
Thanks. So I'll talk about what we were trying to do. I mean, there are a couple pieces of this. Obviously, that we know that buprenorphine is more available in white communities than in Black communities and Latino communities. We also know that we don't have culturally competent care when we have such a limited number of caregivers who reflect the communities that they serve. So there were several pieces that the federal government was seeking to do, which is to increase the number of fellowships, to increase that workforce capacity so that individuals can get the type of care that they need to help them. And then also there was lots of work that was being done just in terms of making sure that we were collecting the data, because the data that has been collected does not always allow for that granularity to really see where the inequality is occurring.
So let me ask, before I get to Michael Kuzno's question, I want to give you a chance to talk about some of the work you're doing. I mean, my view as someone who's done community-based research with people who use drugs for 30 years is that the sophistication of the federal policymakers in the space has improved dramatically, over my 3 decades of observation. How does your new training program fit into that sort of workforce need at the federal and state level?
Yeah, thanks for asking that, because I feel really strongly about this. I mean, I'll tell you that, so this new Master of Addiction Policy program that we have, I tell the students all the time, it's a fairly small cohort because we're just starting, but I tell the students all the time that I'm not going to tell you exactly, I teach the seminar. They take neuroscience classes as well as policy classes. I said, by the end of this, you're not necessarily going to know the answer to every question, but you're going to know the questions to ask. Because I really feel, I mean, some of this you can't always control the politics of it, obviously. But I like to think that maybe you could slow it down a little bit, because so many of the really bad policies that were passed were the result of not well thought out things. And the crack cocaine disparity is a perfect example. That legislation passed really fast. And you can keep, I think you don't get credit for the things you stop from happening. But when you're in a government position, there's a lot of stuff you keep from happening. And I think the addiction policy folks that we're trying to train to work on the state level, to work on the federal level, the whole purpose of this is to have people who can pursue good policies and keep bad policies from going forward.
That's a great point. So I'll now ask the question Michael Kuzno put into the Q&A. Many health policies, including those related to substance treatment, are controlled at the state level. It's not clear how state and to some extent local policy changes are needed to bring about these changes. Could you comment on the interface between federal and state policies?
Yeah, great question. Because I had spent a lot of time working on the local level and state. And so what the Office of National Drug Control Policy Strategy is intended to, while it is a blueprint for federal drug policy, it's also intended, and it has in the past, provided a guidebook for state policies and local policies as well. And, the fentanyl test strip piece is a good example. Even syringe services programs at the federal level, when we started scaling up the availability of that, it started having end naloxone. I remember when I walked into the Office of National Drug Control Policy, and we hadn't really pushed naloxone much. The prior administration hadn't, not Trump, but the administration prior to Obama. And we were talking about it quite a bit. And I remember going to a conference and people saying, wow, you're talking about this a lot. That's really a marked change. And I had not recognized that. I didn't realize that. But states started following suit. And so the federal government can amplify policies that are good. It can also amplify bad policies. I mean, we've seen that. So I think those are two examples, the fentanyl test strip, latest example of where states are now starting to fall in line and making sure that they're changing the laws. And then also the syringe services programs. I mean, one example actually where states are further ahead than the federal government is on medications for opioid use disorder. In the states are actually doing that more so than the federal government is right now.
Okay, thank you for that answer. So the next question, you mentioned a bit about reducing incarceration rates for drug charges throughout the talk. What do you think is possible low-hanging fruit? For example, would decriminalization or safe supply be considered low-hanging fruit in sort of the paradigm you laid out?
Well, I think it goes back to the low-hanging fruit definition. Whenever you talk about criminal justice, anything you talk about criminal justice is like no-brainer, you should do this, but not really low-hanging fruit when it comes to politics. And if you are, if you're following the Supreme Court nominee conversations, there have been many questions that have been directed to her about sentencing, about drug sentencing, about soft on crime. So I think that certainly changes in scheduling, legalization, decriminalization, those are all important matters to consider. It's not necessarily low-hanging fruit in an election year. And I'm just saying from a political standpoint, that's difficult. Doesn't mean that people shouldn't pursue it. It just means it's going to take a little longer.
Yeah. What would you say? So next question is, I'm wondering what you would say to media or social media outlets that have mischaracterized the Biden administration's approach to advancing harm reduction. It's a little bit related to what you just said, but go on.
Right. I think, harm reduction is such a Rorschach test. I think there are some people who don't like to use it because of that, because it means a lot of different things to a lot of different people. I wasn't serving in the administration when the issue came up about crack pipes. I think that was, we know why they use that term. Sometimes when you're in government, you just kind of you just keep looking forward and you do what you think is right. And you're not always going to get credit for it that day, and that's okay. Maybe you'll get it later on, but what really matters is, are you doing the work you need to do, and are you pursuing the policies you need to pursue? And that $30 million for harm reduction services is going to get out to the states. It's going to be spent well, and it's going to make a difference. So that's kind of what you have to look at.
Okay, next question is, a lot of our drug policy tends to look in the rearview mirror rather than look forward. Given the substitutability of drugs in use as well as supply, how can we get agencies to look forward? For example, medications for opiate use disorder is important for opiate addiction for sure, but it will do very little for managing stimulant use, including methamphetamine misuse. How do you get governments to think broadly about addiction? Yeah,
so I think a lot of the attention that's always paid to what the actions is to overdose deaths, and that's become the metric by which we judge how successful we are. The issue of stimulant use disorder isn't as the focus isn't as high on that in the public's mind or the media's mind, but in the administration, we paid very close attention to this because you could see the numbers going up. And so there is research ongoing for medications for stimulant use disorder, but more importantly, the work that's being done, and I know California passed a law on this, to pay for contingency management and to change the rules that lead people to believe that you cannot use contingency management. So there was an increase in the amount that can be used under, I believe, under SAMHSA rules. So, you know, we can do two things at once, but the thing that really gets the most attention, obviously, was overdose deaths. But the National Drug Control Strategy is going to come out later this year. That strategy, which is issued annually, looks at a broader array of issues rather than just focusing on opioids.
And then we have one more question, and then I'll ask something to just give you a chance to ride off into the sunset. All right, so before we get to that, the next question is, I understand the need for harm reduction, but primary prevention needs to be sought with the same vigor. On your slide about drug policy priorities, what is the plan for reducing youth substance use? I see this as a long-term plan, but there's also the overdose from fake pills that may not have anything to do with addiction. Is this part of reducing illicit substance use?
Yeah, thanks. So there are a couple things. One is that, you know, again, the administration and the executive branch generally has for years had drug-free community coalitions. I think they're up to 900 coalitions around the country that are efforts to reduce youth substance use. That's one thing that is funded by the government. The other piece that we were looking at is the role of trauma in substance use and the role of adverse childhood experiences, and how we could, with the Centers for Disease Control and Prevention, are there pilots that we could do to address that issue? And then the last piece, so there was a large focus on primary prevention, but the last piece you raised about counterfeit pills, fake pills that have fentanyl in them, you know, really important piece of this. There were efforts that are continuing to work with online companies like Snapchat, so that, you know, they know that if those counterfeit pills are being sold using those interfaces, that's illegal activity. And also a lot of awareness raising that goes on with parents about that. That is, and you know, so that's not part of a long-term trajectory of a substance use disorder. That could be someone getting, you know, what we've talked about, which is poison supply. So those are important pieces. That's another reason why we got that fentanyl test strips out, because we wanted to make sure people knew that these substances can be deadly.
Okay, and let me just acknowledge the next comment is from someone who lost a teenage son to poisoning with a fake pill. And I feel like you've addressed that question, but let me just ask it just in honor of that. So do you believe, and I think there's probably something to say here, do you believe we are evaluating youth primary prevention programs from the perspective of this sort of poison supply
Yeah.
challenge?
So I know that, yeah, I'm sorry for your loss first and most importantly. And I think that the issue of the poison supply and an individual getting one fake pill, we've seen an increase in amounts of fake pills. We saw, I'm not privy to this right now, but we saw an increase certainly in pressed pills coming across the border. And the Drug Enforcement Administration was doing work to inform parents about that. And there's been lots of efforts being made through prevention programs. The way that the drug-free community coalitions work is that they respond to the needs of the local communities. And so if the local community is seeing an increase in fentanyl pressed pills, I know this is a big issue in Arizona, that information campaigns will go out, alerts will go out to make sure that people know that they should not be purchasing these drugs. This is what they look like, and they are likely counterfeit, and they're likely fentanyl.
Okay, so I think we do have one last question. There are logical ties between certain drug policies and the stigma around addiction, which can deter people from seeking treatment and influence public opinion of harm reduction. Are there policy approaches that can reverse or mitigate that stigma and inspire a more positive view on treatment and harm reduction?
Yeah, I mean, that's a good question. I think, we always think about education, and my old boss, Michael Botticelli, always said, I don't think he coined this, but he always said it, you can't hate up close. And so the more we talk about, the bravery of people coming forward and talking about their children, who they may have lost, the bravery of people in recovery who can come out and say, I am an individual in long-term recovery, this is my experience. You can't hate up close. And so those types of approaches can help. We're not going to eliminate stigma overnight. I mean, one of the reasons we have this stigma is because we built it up to protect ourselves, right? I'm not excusing it, but we did. I'm a parent, and, I think that as parents, sometimes we think we have to stigmatize people in order to make sure my kid isn't doing this. So it's going to take each one of us, reaching out to people, making sure they know. I'll tell you one thing, and I think it harkens back off into the HIV/AIDS movement when people talked about themselves publicly. That's really hard. But the obituaries now are starting, at least, to say, my loved one died of a long-term illness and died from an overdose. So they're much more public about it now. So I think that it's making sure that doctors say they don't want to, one of the reasons they don't want to use buprenorphine is because they don't want people with substance use disorder in their lobbies. We need to make sure that doctors know they're already there. They may just not be talking about it. So it's really on each one of us to overcome the stigma that all of us have in our approach to addiction.
So let me just conclude then with this last thought. And again, your remarks have been fantastic and very informative. So I personally really appreciate it. And from what I can tell, it looks like the audience has enjoyed it as well. One of the things that's troubled me for a long time about our response to health challenges faced by people who use drugs is that even though we do have an ONDCP, we don't actually have a community infrastructure that exists. And it's analogous to what happened with HIV, where there was the development of HIV care coalition or care planning councils and also prevention planning councils. They're expensive, but the empirical evidence about their effectiveness in sort of directing funds to evidence-based strategies, both for treatment and care, is actually pretty remarkable. I mean, it's something the CDC should be very proud of, and they probably don't get enough credit for that infrastructure. I do wonder with the overdose and the fact that, it is different in every different communities and different age groups and different exposure levels. Has there ever been conversation about replicating that, either for overdose in particular or for poison drug supply, or for just the fact that fentanyl is now dominating the opiate market, or even that's, methamphetamine use has really blown up as well?
Yeah, I think there has been discussion about that. There have been some legislative proposals along those lines. I think that we've just like we siloed the addiction treatment system outside of healthcare. We depend a lot on grant programs that are already in place, and so this would take kind of upsetting the apple cart sometimes by taking some of those grant programs and maybe changing them, shifting them. And I think that's probably what's standing in the way of getting that done, is that people are already bought into the existing systems, even though they may not be working or that there's a better way. There has been legislation proposed that hasn't gone anywhere. The price tag was pretty high.
Yeah. Okay, do you have any final remarks you'd like to make?
No, thank you so much. I have looked forward to this, and I'm really interested in the work you all do. I've been following it since you began, so I appreciate the opportunity.
All right, thanks so much for joining us. I'll let Adam close us out.
Well, thanks. Yeah, that was a great, great talk and lively discussion. And I don't know if we've had that many questions from our audience in the history of our Distinguished Speakers series. And so anyhow, so thanks to Miss LaBelle. And just check out our upcoming talks. We have a number of great speakers who you'll be able to see, including Dr. Gupta, who will be an interesting follow-up to Miss LaBelle's talk. And stay with us. And if you're not a member of our listserv, please let us know, and please email me or Vicki Williams, and we can add you to our community listserv so that you can get notices about the Institute's talks and other ongoing stuff that we have. So thank you so much for attending. Have a great day.